David, what prompted you and GSTHR to look into this intersection between smoking and drug use?
It's an interesting question. Actually, in some ways, it's a surprise it's taken us quite as long to get round to it as we have, because most of the people who work on the project have a background in drugs and drugs policy and drugs harm reduction. So it's been something that we've been thinking of doing for a while. It actually took us quite a while to get to the finished product. It took us a year from starting, from conception to delivery. But it was something that we've been meaning to do, and I think we're all very pleased actually with how it's turned up, both in terms of the process and the end product.
What is the global state of tobacco harm reduction?
Right, so this is a programme that's funded through Global Action to End Smoking, and it's the briefing papers, of which this is one, is part of that. Other parts of the GSTHR programme include the website, which gives a global overview of the regulatory situation and what we have in terms of data on every country in the world, and it also runs a series of events to promote the potential of tobacco harm reduction.
So what were you hoping to learn?
From this particular thing, well, I guess it was to engage with people who are actually working in drug services. A lot of that was done in the UK, but we had some input from other countries, including in Central Asia. We're very conscious that, you know, this is a global problem. It's interesting actually to see how the sort of proportion of smokers and people in drug services is often replicated in many, many different regions. So what we really wanted to do is see what's happening, which sadly, unfortunately, is not a huge amount, but we wanted to see what we could do to help encourage more drug services, more harm reduction services, to think about how they can consider smoking within the people who use their services.
Now, historically, has there not been some reticence amongst drug harm reduction folks?
There has, and I think in drug services generally, and I can go back to when I was involved as a trustee of drug services, you know, smoking wasn't necessarily seen as one of the things that we did. You know, often, you know, there was far more apparent immediate problems and, you know, kick the smoking can down the road. I can remember my moment of thinking, actually, that, you know, I think we could do this, and it kind of worked in the service that I was involved with. But it's still true to say that a lot of services, you know, they're focused on the here and now. They're focused on dealing with the client who's turned up, the person in front of them who's got a drug problem. They're funded often just to deal with that problem. So, you know, very conscious that in some ways asking them to, but what about the smoking? It's another burden. In a lot of cases, it's an unfinanced and unresourced additional bit of work. But one of the things we hope this encourages is people to think that actually some of this isn't resource intensive. It's not going to require a lot of money. And hopefully in some places it encourages agencies to go out there and find where there may be support for them to do things that might need a bit of money to help.
Tobacco harm reduction as a movement could benefit if the drugs harms people were out there banging on the doors of government looking for funding to add these services to what they're already doing.
I think it could help, and I guess one of the things that's become very evident during the process to produce the briefing paper and the implementation document is that actually, you know, harm reduction is harm reduction. And, you know, this fits very well. Tobacco harm reduction does fit within the broader harm reduction agenda. You know, it's the same principles, you know, it's very person-centred. You know, you do it with people, not to people. So it can fit in quite well like that. But as I've just said, you know, we're very conscious that a lot of services are under a lot of pressure. And it is, you know, do we really want to be thinking about another problem? But yeah, point you make, the potential is massive.
Often it is that immediacy issue when it comes to some of the reticence, because Somebody's got a, hard drug problem, and they're on the street, usually their life is in danger now, whereas tobacco can take 20, 30 years to kill you.
I think that's really one of the big problems. Yeah, someone presents, you're dealing with the person in front of you. Their lifestyle is probably quite chaotic. They're possibly, looking to go to court, or they're known to the police. There could be immediate issues with family. There could be some very acute health issues that you're dealing with. So it is difficult to say, yeah, but what about they're doing something that might not kill them for 2 decades? I think when you can get to the position, and one of the things that we evidence here, and there is good evidence from lots of pieces of research, that when you look at the long-term outcomes, that's where you get the real payoff. We know that drug services are really good at keeping people alive. Just being in contact with a drug service, a harm reduction service, increases your likelihood of living. Yeah. But if you look down the track, the people who are known to services, unfortunately, many of these people do die prematurely, and about 1/4 of those premature deaths are smoking related. Right? It's almost the same level as the number who will still be at risk from dying because of drugs.
Now that's what's extraordinary. I think from this research, and correct me if I'm wrong, but the numbers were 24% due to smoking-related illnesses, and 28% due to drug-related deaths. So, wow, that's not far apart.
No, not at all. And in certain services with certain cohorts, if you're looking at the people who have had the most severe problems, that it's very evident. We're talking about people who are dying prematurely in their 40s and their 50s, often of smoking-related causes. So that there is a lot there, that there is a huge potential there. I guess if I was trying to do the sales pitch, generally, not just to the hard-pressed drug worker or drug service, this is about getting the maximum return on investment. We know drug services offer a great return on investment in terms of the money spent, the outcomes, keeping people alive, helping people, live longer, healthier, better lives. If we can add smoking and reducing smoking into that mix, we really improve that outcome even more.
Tell us about the research. Was it 100,000 heroin users in the UK?
Yeah, so that's from the English data about people who are entering drug treatment. So we have very good evidence about rates of smoking amongst people when they come into services. It also tells us about how many of those people get support around smoking, which is not anything like as many as I'm sure any of us would like. But we also have other research which that shows many of these people are motivated to give up. If you say, would you like to give up smoking? A lot of them would go, yeah, I really would, but it's difficult. And so, we need to encourage people to have that conversation, to offer the brief advice, just to start that conversation going. And for a lot of those people, that you will be able to start doing things with them. And tobacco harm reduction is, it's another tool in your kit, because we're not necessarily saying you've got to give up nicotine. If you want to, you can. Great, brilliant. But if you're really worried about that, there are these alternatives which work for a lot of people. We've got very good evidence around that the most successful tools for smoking cessation are vapes and some of the other reduced risk products. Bringing that into this space, huge potential for people.
Just how big of a problem is smoking amongst this population, and is it higher, obviously, than others?
It's much higher. I mean, in general, if you were talking about people in contact with drug services, and this is interesting, this is one of the things that's replicated around the world, you get typically smoking rates that are 2 to 4 times higher than national averages. If you look at people in particular, groups within that, and opiate users are the ones that we've got the sort of good firm evidence in England on, you'll see smoking rates at 75, 85, 90%. In reality, there are some services where everyone using that service smokes. You know, and if I go back to, you know, the drug service that I was involved with in East London, you know, when I was going in there for the trustee meetings, you would see many of our clients sat on the wall outside and they'd all have a cigarette, you know, and it was, you know, that was just a fact, and you kind of accepted it. And I think there's a problem there because it's normal. It's normal within the group. Smoking's you know, the norm. And as a drug service, as a drug worker, well, yeah, everyone smokes. It's a bit, you know, we see it every day. And that kind of, you can overlook it. And, you know, as we touched on, and anyway, you know, at the moment, there's things that could kill them today, tomorrow, next week. They, you know, they could be back in prison. I'm working on trying to avoid all that. To say, yeah, but what's their lung health going to be like in 15, 20 years can seem, you know, a big ask, but it can be done. And, you know, one of the things that I know, and, you know, this is into the realms of the anecdotal, not evidential here. You know, I know some of the people who were in contact with drug services who were helped to give up smoking, and the impact it had on them was visible. You know, they were really proud that they'd achieved this. You know, I've given up the fags. You know, and, you know, there's bits in them. My kids say, I smell much better when they come around. They say the flat in my apartment smells much better. Real pride, and, you know, and you could see, you know, this was a big win for people. And, you know, again, this changes from country to country, but in the UK, you know, if you can move someone from smoking, and a lot of these people smoke quite heavily, to, say, vaping, you're putting money back in their pocket at the same time. So, you know, that's real time now wins.
Money back in the pocket, improving their health, and as importantly, improving their own sense of self-worth.
Absolutely, yeah.
So how could public health not get behind and support that?
Well, I think, to be fair, some people do. And, you know, and we've seen in the process that's led to this, we've had some very positive engagement from agencies delivering these services and others. I think lots of people are still very wary around tobacco harm reduction because, you know, tainted by the big evil tobacco companies. It's very difficult to move on from that. You know, we are cursed by the history of, you know, the tobacco companies' behaviours decades ago, but it still influences attitudes and behaviours now. And this whole idea that all these reduced risk products are, you know, but they're all, you know, they're all invented by, it's just a big tobacco conspiracy, is, you know, many people, even if they know that's not quite true, why do they want to get involved in a subject where they might get a lot of flack from people who go, oh, you shouldn't be involved with that? It's a very simple position to be in. Oh, we don't want to have anything to do with this and people should just give up. But there is a conflict there. I mean, I have colleagues, friends, who would have no problem at all championing drugs harm reduction. You know, they would be very happy to stand up and say, needle exchanges are a vital part of any sensible public health approach. Of course, we should provide methadone and other opiate substitutes, you know, great benefit to individuals and communities. And then they would feel very uncomfortable saying, and vapes are a valuable public health tool. A lot of people would feel uncomfortable doing that. And it is partly because, you know, it isn't coming from the medical health establishment.
It's interesting because, you know, for those in the medical health establishment and public health that have come around to drugs harm reduction in the last, say, 20 years, and many have. I mean, you know, many governments in Canada, for instance, very supportive of all of those efforts. And they often talk about how that we must respect the autonomy and dignity of the drug user because, you know, that's the way to support them. Yet they don't accept the autonomy or dignity of a smoker who's trying to save their own life using safer nicotine.
I think these smokers do seem to be one of the last groups which can be treated in a way that we, you know, just wouldn't accept with any other group. I can't think of an equivalent now, but you are right. And you can see this in the failure to engage with smokers or, you know, even representatives of groups that use safer tobacco products. It is, it's remarkable to me. Actually, these are somehow, and it's because, you are talking about the same people. You could be talking, when I am talking about David and his opiate or his crack cocaine problem, I will be conscious of my language. I will not want to be stigmatising. I will, want to hear. I would really appreciate his involvement when I'm considering my service design. You're not going to see a lot of that around smoking services or tobacco harm reduction yet. But I think, we need, smokers, and, this is a reminder, do not live in isolation. Many of them will have other health challenges or have other issues going on. And, we need to apply what we know works in other areas to this area as well.
All of this over nicotine, that's a shocking position to be in, considering, of course, your experience dealing with people who are addicted to much more unhealthy drugs.
I think nicotine, it does have its own it triggers its own responses amongst professionals. I think when we look at smoking, I think one of the things that actually, that while people can say, true, 50+% of people who smoke regularly are going to die prematurely because of their smoking. So actually, it's how you consume your nicotine dictates the danger, and that's really high. I mean, 50% of heroin users do not die from heroin, so at that level, smoking nicotine is, and yet we haven't really deployed, the full range, the full arsenal of public health responses. We seem to have got stuck somewhere around banning stuff and taxing it, and moving into things that engage more effectively with the people who are using the substance is really quite woefully underdeveloped when it comes to nicotine.
So when I look at the downtown east side in Vancouver, right in my hometown, that doesn't seem to get smaller. The problem keeps growing. And so I often wonder, where are those new younger people coming in? And how come public health isn't, got their hair on fire over the youth that are, vulnerable to moving into, crack, fentanyl, heroin, and all of the other, drugs that are on the downtown east side of Vancouver? They don't seem worried about another generation of young people becoming addicted to hard drugs.
I don't know enough about the Canadian situation to really comment. I mean, you do have a bigger problem in North America with the fentanyls and such like than we do so far in the UK. But I think there is a danger that people end up accepting a level of problem, and it's because it becomes the norm. We've been speaking about, the norm. It's, this happens, and it can get, this happens in this locality. I think there are real challenges there because people do just accept it. And, that's something I can see, perhaps all being guilty of professionally. That area has that problem, and, we'll maybe try to keep a lid on it, but, realistically, what can we do? So I think sometimes there may be a lack of ambition. I do think around smoking, actually, in terms of practical terms, there's often a real lack of ambition. People are very good with the, abstract ideas. We will end smoking, and, we'll set some notional target. Well, what are you doing to effectively stop smoking, in the 2020s? Not talking about what it will be in 2045 or 2050. What are you going to do this year, next year, the next decade?
Is it time that we advance the conversation to not just be about those that are smoking and getting them to switch, although that obviously is clearly the focus, but as every day and year goes by, millions of more people have switched from smoking to using safer nicotine products, vaping, pouches, and so forth. It seems that they become forgotten. Restrictions, flavor bans, all these things, they don't have the same impact on a smoker who's still smoking. They have a disastrous impact on those who have already switched.
Yes, I mean, there's harm reduction often lacks champions generally. I mean, there have been the odd occasional politician who's championed harm reduction, but in general, not. What I think we're seeing here now is a strange reluctance politically in the UK, and it would be shared across the parties actually, to say, actually, haven't we achieved a big win on the smoking? No one's taking any credit for the role that safer products have played in reducing the number of smokers. I also think, it's a great shame that not more effort's been put into monitoring people who have switched in terms of having more data. There's some about what does their health look like. So instead of having good data, we have repeat scare stories that nearly always get debunked about, my lungs collapsed or whatever. It wasn't because of vaping, was it? But we see that. So there is a reluctance, a shame there, and it's a great loss in terms of people, saying, this has worked. We should have a few people up on the rooftop saying, actually, some of this has gone really well. And that would have a wonderful effect to encourage other people to take it on. I mean, we have some quiet sort of tobacco harm reduction champions. We have some quiet harm reduction champions politically. I've worked with some. You don't tend to get many people who go, those needle exchanges were great. Well, why is it that the countries that introduced needle exchange in the 80s and 90s, that they have the lowest HIV rates? It's not magic. It's not a coincidence. But people, are still often reluctant at a political level to lay claim to some of that. The UK almost accidentally finds itself in some ways one of the leaders in tobacco harm reduction. But you don't get many people going, oh, we did well there. Well, that was an inspired policy decision.
When you look at the Global Forum on Nicotine, how does it help play a role in this effort?
I think GFN still, it plays a unique role really in bringing people together to kick around some of the ideas, and there are some sort of more public health, more academic focused meetings, but this is one, and one of the unique things about GFN has always been there's a lot of people here who are consumers of these products, who are often, a lot of professionals do, they would say that, wouldn't they? They're vapors. You could look at them. These are people who have successfully quit smoking. There's a lack of championing of these. An analogy with the drugs world, not always well, but we've often, recognised the value of having people who've come through a programme successfully, championing that to others, to their peers or former peers. Look, you can turn your life around, you can live a healthier life. We've kind of ignored a lot of that. We've had pockets of individuals who have done it around vaping and similar, but we should be, these people should be put in a position to say, this is what works for me. And we are seeing, not just in the UK, lots of countries, you're seeing dramatic drops in smoking and an increased use of safer products. And some people wring their hands and think that's a disaster. And you kind of think, but actually it's a real public health gain.